Welcome to our session, a strategic analysis for hospital administrators on optimizing departments' resource allocation, cost measurement, and financial sustainability. Hospitals around the world are under financial pressure. Populations are aging, new technologies are expensive, and healthcare demands keep rising. Meanwhile, hospital budgets and resources shrink. All departments must do more with less. Understanding costs is no longer optional, it is essential. In this session, we'll explore why costs matter, how to classify and measure them, how to apply this knowledge to improve operations, and how to strike a balance between efficiency and quality. Let's take the emergency department as an example. Despite high overall healthcare spending, emergency departments account for a small slice, just 4% in the US in 2019. Yet the emergency department is crucial. It's the gateway to inpatient care for one-third to one-half of all hospital admissions. So why is it so hard to understand costs? Because costs are often hidden in inpatient budgets, distorted by outdated accounting, skewed by unfair overhead allocation. In one case, a new emergency department leader discovered the department was being billed for hospital CEO's personal expenses. Transparency is the first step to smart decision making. To understand the types of costs, there are two main categories of total costs. Fixed cost, these don't change with patient volume. Examples include rent, salaries, equipment, utilities. And then we have the variable costs. These scale with the number of patients. Examples include medication, dressings, testing supplies, lab work. Together, fixed and variable cost make up the total cost of operation. Average cost equals total cost divided by the number of patients. Managerial cost equals the extra cost of treating one more patient. At first, every new patient helps to reduce average cost because fixed costs are spread more widely. But eventually, capacity limits hit. Add another CT scanner or physician, you now face step-up costs, a big jump in overhead. To manage this well, leaders need to understand the capacity of their fixed resources, when economies of scale end, and how to justify added expenses with actual value. Larger departments can better predict volume and plan resources. Let's take the emergency department as an example. After about 60,000 patients per year, the benefit plateaus. Beyond that, more patients mean more stress on the system and more costs. Cost distributions in the emergency department is typically 60 to 85% personnel, therapeutic products, drugs, equipment, IT, administration is the rest. So while it seems logical to cut staff to save money, this is risky. You don't improve efficiency, fewer staff means more delays, more errors, and worse patient outcome. In some systems, some departments bear the cost of care, but other departments receive the reimbursement. This means departments deliver services they're not paid for, creating a budget gap. Solutions: advocate for fair revenue sharing, bill other departments for services rendered, push for reimbursement models that reflect departments' contribution. To manage resources well, you must track costs not just department-wide, but per condition or patient group. Variable costs are easy to assign, linked to patient care directly. Fixed costs are harder. They may be allocated based on time, space, or usage. Take personnel costs. The best method is using capacity cost rate. Example: a nurse earns 87,000 per year. She works 112 productive hours per month. Capacity cost rate $1 per minute. If the nurse spends 20 minutes with a chest pain patient, that costs $21 in nursing time. Multiply this across staff roles for a full labor cost per case. Overhead costs like human resources, information technology, marketing are often assigned using metrics like square footage or number of patients. This can unfairly penalize departments with high volume. Modern approaches like activity-based costing from Kaplan and Porter offer better transparency, align costs with actual resource use. Why does this matter? Because poor accounting can make an efficient department appear to be losing money. That misperception hurts funding and morale. Cost measurements also informs investment decisions. Let's talk about a real-world example. Point-of-care testing for shortness of breath. In a German study, this added 2.84 euros per patient, but cut the emergency department length of stay by 45 minutes, improved satisfaction, and reduced walkouts. So even if pure cost analysis says don't invest, broader value-based analysis supports implementation. Departments face growing pressure to cut costs and increase efficiency. To meet this challenge, leaders must understand fixed versus variable costs, measure marginal and average costs, use accurate activity-based costing, advocate for fair reimbursement, know how resources scale with patient volume, and evaluate investment holistically. Because in the end, cost decisions must never come at the price of patient care or team sustainability. Thank you for joining us in this session for Cost in the Healthcare.